Hi all, welcome to the fourth session of our clinical training on orthopedics, Marma and Bandaging Techniques, basic level. Okay, this is the fourth class we are going to have, and it is regarding the examination part of hip joint. Now, hip joint, we all know it is the core part of our body. Every movement happening in our system will have any activity you do, hip plays an important part, and that's why it's called as the core. And many a times right now we can see in many of the videos that are being played on online, you can see that the core strength, like flat planks, those kind of and calisthenic workouts, all those intend at the stability of our hip. Now, if we have a strong hip, it's considered that we are having a strong core. The reason why, because you might have learned about the origin insertion of our muscles and all that, and origin always it's towards the center of the body, and that's clearly evident from when we learned the pelvis, the pelvic girdle and all that. Because except two muscles, our external obliquus abdominis and psoas minor, the rest of the all muscles have origin from the hip area or the hip bone. We say the ilium, ischium and the pubis together. And remember the joints that form in that area. We have anteriorly a very close joint formed by the two pubis together. We call it the pubic symphysis. And then we have the ball and socket joint, that's our hip joint that is formed by the sides. Synovial joint, a large one, and then at the posteriorly we have the sacroiliac joints and the sacrococcygeal joint that form, and above we have the lumbosacral joint that is formed. Now see, these are all very especially the symphysial, very pubic symphysis, very limited movement is there. The sacroiliac also, the movement range is very limited. But at the lumbosacral there is some form of movement. Coccygeal, we even don't know the movement happening at all. The hip movement, yes, it's a ball and socket joint, so the range of movement is very high, but the range can be limited by multiple factors. How obese you are, how mobile you are, all those determines. You can see gymnasts doing all sort of movement, like a shoulder joint, how a normal person can do, the same way they can move their lower limb hip joint. That itself shows that the dynamics of movement that we can attain with the hip is very high. But many a times we won't do that also. We restrict because of our sedentary lifestyle, many a time these range of movements we lose. But we can attain by slowly stretching the muscles and strengthening the muscles in that area, we can attain. Now, whenever we say about a hip, you need to think of multiple things, multiple organs that come inside our abdominal cavity, which can radiate pain to the hip area. But the examination, so that's why it's very important. It not just includes the spine part, it should include the abdomen, it should include the pelvis, the groin and even the thigh area. Now, as our joint, all the joints when we learned, we had the same principle which we follow, the look, feel and the move. Now in the look, as the patient comes in, usually the patient will be standing, look from the front, the sides, the back and all that. Usually that's a first form. As the patient comes inside the OPD itself, if the patient is coming with a back pain, you will be able to ascertain, because the manner in which the patient comes in will clearly state the condition of his hip. Now remember to look for walking aids. Even if the patient, sometimes what happens, the doctors will be busy and maybe the assistant or the interns who are there will be making the patient lie down. Maybe the doctor might not have seen the walking aid the patient was using. So that can result in some confusion. So always look for walking aids, use of heel raisers. So examination of your shoes or chappal or whatever you are wearing, that's very important in terms of, because that gives us the clues also. Now look for once you look for the skin part, once the area is exposed, look for surgical scars or any of the sinuses or anything in that. Now the soft tissue part, that's another important thing, because you can check for muscle wasting, any inflammatory things, any other swellings in that area, definitely think of hip arthritis, maybe neurological conditions that might arise in that area. Keep those in mind when you are doing a inspection of that area. Now, with the bone part, usually look for the posture. Remember, if the patient can't lie down properly with the back fully extended, you can clearly make out that there is some problem with the hip part. Then the posture of the limb. Remember, that is very much important, because usually our limb will be, whenever our foot, consider my hands to be the foot, usually it will be slightly externally rotated, and it will have a slightly sagging position. If you lie on the bed with your in a supine position, usually this is the position which we keep our legs. Now this is the word. Any alteration in change in position will give us a clue. One foot is externally rotated, the other one is internally rotated. That itself gives us a clue there is a dislocation, or maybe a joint or a muscle pathology that might be causing the problem. Okay. Now the second part, we go into the feel part. Usually we look for feel. Feel is definitely by the hands. We need to palpate and see. When you see, we will have the soft tissues, tenderness arising. Remember, easily we can palpate the entire back area. And there the clinical anatomy which we learned in first year comes into play. Whenever we put our hands at the top of our iliac crest, at the highest point of iliac crest, and cross and touch at the back, we will be usually touching between the L3, L4 region. Now above we will have the L3 spine, below we will get the L4 spine. Once these two are there, then it is easy. We can, with an indelible ink or a skin marker, you can actually mark L2, L1, all those we can mark. Once it is marked, what's the advantage? The advantage is when you do the palpation, where the maximum tenderness comes up, or we call the trigger point, where it comes. A simple intervertebral disc prolapse can be diagnosed from there and there by easily, because the palpation will give you a pain at L3, L4. You can clearly state that yes, the patient is having some, and definitely you should advise the patient to go for an X-ray, or X-rays, IVDP is not possible to find, but other anomalies, osteoarthritis, all those things we can get it. Then, or else a CT or an MRI can be advised, where you can clearly get the pathology not fair. But clinically, if you do the manipulation, it will be easy. Remember why many a times the patient will come and say to you that I am having IVDP, because that's the first thing you will get when a lower back pain is typed in Google. You will get the first diagnosis is IVDP, because patient will come and say that, sir, I am having IVDP. Now many a times it might be a muscle spasm in that area. Remember about our erector spinae muscles that run the course, because it has a very close affinity with our spines and the spinous processes and the transverse process. Remember the muscles involved in that area. Basically it's three muscles. The anatomical part, I am not going into the deep part. You have to remember the spinalis, the longissimus, the iliocostalis and all. Now the muscles, these muscles are the erectors. Maybe an erector spinae spasm will be the reason. A simple Abhyanga and some Sweda procedure and some medications will be enough to bring down that condition, and the patient will be back to normal. Just strengthening exercises after that will be enough. And remember about sometimes it can be a bursitis, or sometimes it can be an enthesopathy. Enthesopathies are usually enthesis. Enthesis is the area where usually the muscles, the tendon come and attaches to the bone. That area is known as enthesis, and there might be an inflammation. Then it will be called as enthesitis. So in such cases also, you might have when you palpate the area, you can have a tenderness being elicited. Now once the palpation is done, then is the third part. That's the movement part. How the hip joint can be moved. Remember, the hip can be moved in multiple ways. The first and basic thing is the flexion, extension. Then we can have the external rotation, the internal rotation, and we have the abduction and the adduction part. Now these are the basic 6 movements that are available for the hip. Other circumduction movements and all that are there, which is normally not done in a clinical atmosphere, but yes, in advanced certain conditions we can do those tests also. But basically remember this one. The easiest way is to understand the hip flexion and the hip extension. Usually this is the way I do. It's called as a modified Thomas test. Now the test is done in such a way that the patient is asked to come into a rolling ball position. You can lie down on somewhere and you can flex your entire and like you are holding to the knees. Now in such a way, when you are holding the knees together, that is called as a rolling ball position. It's very easy. You can lie down on the bed and always tuck in like to the chest, the knee can be, and then the hip flexion will happen. Now in hip flexion, remember that if the patient is comfortably able to do that, then there is no problem. But if the patient is having any pain, anything is there, then definitely you should be cautious, because we have the two hip joints on both sides. Now what we will do, we will ask the patient where you have the maximum pain, whether it's on the right side or whether it's on the left side. Now if the patient says that it's on the right side, so that means the left side is the healthy limb. So we will ask the patient to extend the left leg. Patient will comfortably do, there is no pain and all that, then it indicates that it's regarding the hip part. Now if the patient is asked to do the opposite limb and the patient is saying uncomfortability, then we can confirm it is the hip joint only, not the sacroiliac. Not the sacroiliac. Now the way in which we will determine the sacroiliac strain is also, you can have with the help of this one. Now if the healthy limb is being extended and the patient is saying that he is having a pain, then we will know that yes, it's a sacroiliac that is stretching and that is causing the pain. Now there is another advanced test that is called as the Gillies test that we can do to determine the sacroiliac strain, and that I will explain once the hands-on training is going on. Right now remember about this one. Now the rotation part, the internal rotation and external rotation, that also will be demonstrated at that point. When the hip goes or the femur and the tibia, remember that part, the femur and the tibia goes inwards, inwards, and the foot goes outwards. Remember the knee is flexed at 90 degree, the hip is around 40 degree of flexion. When the foot is taken outwards, we have an internal rotation of the hip happening. The same way when the foot goes inwards and the knee goes outwards, we will have the external rotation that will be happening. Now adduction and abduction, it is easier in a standing posture or on a lying posture. The patient is asked to abduct, move away from the center of the body, abduct and adduct. Adduct is in the opposite direction of the patient, how much he can bring the leg crosswards. That's the adduction that will come in. Okay, these are the ones. Now we will move into the special test. That's one of the special tests that is known as a Trendelenburg test. Now Trendelenburg test you might have learned with the varicose vein also, that's a modified Trendelenburg. This one is that one that is done for the hip joint. In Trendelenburg test we will ask the patient to stand. Now with that we will be asking the patient to keep their hands on our hands. We are also standing on our hands. Now both the hands is on there, and we will ask the patient to flex one limb, like one of his the patient will be asked to stand on one limb. Now if in a healthy patient there is no problem, the patient will be able to transfer the weight to one limb and stand normally, there won't be any issue. But in case of a patient with a compromised hip, you know what will happen? As the patient takes the weight on one limb, if that is the weaker limb, there will be a pressure applied because we need to stabilize, correct now? So that's why we are keeping the hands on the patient's hands will be on our hands, we will be holding it. There will be a pressure applied by the patient so as to balance, and that increased pressure from the opposite hand as they take weight through the weaker limb will give us the clue that gives us that there is a positive Trendelenburg test. Hope you understood. And when we are coming for our online training, we will be explaining this. Another thing you need to keep in mind is leg length discrepancy. LLD we call it. There are two types of discrepancy. One is apparent and latent one. Now the thing is, it is the inequality in the leg length discrepancy. There can be a real difference, that is, real difference means obviously by birth itself the bone length is reduced, and that might be causing the leg to be on a shorter knot, maybe tibia, maybe femur, anything. Maybe there is no neck of femur for the patient. All these things can cause leg runner, and that can be tilted. And for a patient who is having a leg length discrepancy, what will happen is there will be a tilt in the hip that will be happen. There are two types. One is the real LLD and the other one is the apparent LLD. In real LLD, what is happening? The real LLD, the patient will have the leg as short. And in apparent LLD, usually it is because of an injury or because of a muscle problem or because of another hip issue that might be causing the limb to be on. Remember, for the patient, both are the same. Patient doesn't know whether it is real or apparent. So for patient, it is the same and they will complain it as the same, but the treatment is where the variation happens. For real LLD, remember that the treatment is difficult. But in apparent LLD, it's not the LLD we are treating. We will be treating the muscle injury or any other injury that will be causing the leg length discrepancy. Now, common other causes of inequality or in the hip or limb length inequality are, we can have osteoarthritis patients. You can see the way they walk itself, like a waddling duck-like walking. That's usually seen in osteoarthritis of the hip. Hip fracture, hip dislocation, hip dysplasia. Even Hippocrates has explained these things way back at that time about his dysplasia. Remember, his dysplasia is nothing but a congenital abnormality. Avascular necrosis, that's a very important thing that has to be kept in mind. The blood supply to the head of the femur is being cut off. And finally, there can be a fixed flexion deformity also that can cause the problem. Now, being said all this, another important point to note with the hip part is the gait part. Remember, gait is where we all learned about gait in detail, but gait is something is very much important in terms of hip when you examine the hip patient or anything. Now, gait is a dynamic process, correct? We understand that it as a dynamic one. We will have a heel strike, then we will have a loading phase, then we will have a swing phase, and after the swing phase, what again we will be coming to the pre-swing and then to the heel strike phase. Now it has a dynamic cycle to that part, and a lot of muscles also work in that. If you learn about that one, or any injury to any of these muscles, mainly the gluteus, our tibialis anterior, tibialis posterior, our sural muscles, our hamstrings, our peroneus muscles, our the dorsiflexors of the foot, all plays an important role. If any of them is spastic, we will have a awkward gait. But remember, gait is important. Why gait is important? Because you have to understand, whenever a person is walking, 80% of the time the weight is borne by a single limb. Only 20% of the time is when both the limb will be carrying the weight. So weight bearing is high and demanding. And remember, if you are running again, the time time on which a single limb is carrying the weight is very high. And remember, the speed at which a person is running and all that will be causing the changes. Now, gait cycle is important. Please remember that. Remember about the stance phase. Remember about the swing phase. All those things we will explain and also about the different types of gait that you can refer any textbook and find out any the Trendelenburg gait, the ataxic, antalgic, the cerebellar gait, the spastic gaits, and all that. Okay. Now, and finally, coming to the end part of this, we will be coming to assess the impingement part. Impingements that happen at the hip area, and it's called the impingement test. And the test is known as the Fadir test. FADIR. Fadir. It's flexion, adduction, internal rotation. Now, the demonstration and all that I will be doing when I will be having the offline program or the contact class. At that time, we will be doing this Fadir test. Right now, just understand it is flexion, adduction, internal rotation, Fadir test. And that's for the impingement part. One more test is there. It's known as the Faber test. That is also known as the Patrick test. It is flexion, abduction, and external rotation. That's a Faber test. And with this, we come to the end of our hip joint examination part, the details, the marmas, the banda part, the massaging techniques, because in hip area there are a lot of massaging techniques that we follow. All these will be explained once we come for the offline program that will be conducted on this Sunday. Okay, see you guys on Sunday.